Hi, my name is Declan O R from Imperial College London, and I'm going to be talking about putting machine learning into motion with applications in cardiovascular imaging. And thank you to the organisers for inviting me to speak. These are my disclosures. I think it's really important to start any talk about machine learning with patient engagement, and this was an exercise that we did with patients with cardiomyopathy to understand their attitudes and concerns towards AI in healthcare. And I think overall the feedback was positive. I think patients' priorities really are in achieving an early, meaningful, individualized diagnosis, being given individualized information about their own prognosis and an effective management plan, having much greater connectivity with their data and engagement with that. And I think overall, given the appropriate safeguards and given a robust evidence base, I think patients are actually very positive about some of the potential for machine learning in healthcare, particularly around cardiovascular imaging. So this is a slide really just indicating some of the perhaps value propositions of and different levels of at which artificial intelligence can be involved in imaging and some of the opportunities. Perhaps starting with accelerated imaging, I'm going to touch on an example of that in a moment. Super resolution techniques, which are quite exciting for denoising images and fusing different modalities. Image segmentation, so labeling each pixel with a meaningful label, and also giving semantic information, so labeling abnormalities, for instance, on imaging, developing of new imaging biomarkers, and there's been a huge explosion of interest in radiomics, for instance, and computer-aided decision systems for screening, diagnosis, and monitoring. And I think critically, one thing as a community, perhaps we're not so good at, great at diagnosis perhaps, but less good at prediction. So we're going to go to the bottom of that pyramid and just give an example from my colleague Daniel Ruckart in Imperial about accelerating MR acquisition. And I guess we're kind of familiar with the conventional approach of filling k-space, one phase encoding step at a time, and then performing a Fourier transformation to recover the intensity image. But deep learning networks have the potential for learning the mapping between a k-space and the image domain. And the advantage of this is that you can train it on large data sets, so it can use prior knowledge about anatomy of the heart to learn how to reconstruct these high quality images from noisy undersampled data sets. And for example, here's a 6 times undersampled image on the left, and the deep learning network reconstructs that very similar way to the ground truth. And we can push that to 11 times undersample and also get a very realistic image. So I think this is potentially a really exciting idea for using prior knowledge from large imaging data sets for being able to reconstruct very undersampled data sets. A number of caveats, of course. One is that the images can often look good despite very noisy data. We don't know quite how well this will work when there's pathology. But I think it's an exciting approach, and one that I think is being actively pursued for 4D flow data sets, which can eventually take quite a long time to acquire. An example of deep learning to label the pixels is shown on the left. So here we would have a training set where each pixel has been manually defined, and the network will learn the mapping between the labeled image and the unlabeled images, so that we can use these segmentation approaches to define the myocardium and blood pool, the atria and the ventricles, and so on, and label these in a very fast and effective way. And this can approach now expert level performance. But I think critically we can go one step beyond that, and beyond just volumes and mass and function, and start to build a realistic 3-dimensional model of the heart. And I'll show you the advantage of that in a moment. Here's a clinical example. This is pulmonary hypertension. These are 2 patients with pulmonary hypertension, both with the same ejection fraction, 22%, but with very contrasting outcomes. But I think you can appreciate the motion of the septum, the appearance of the right ventricle, there's an effusion on the right, pericardial effusion. There are features in those images that are important for outcome that ejection fraction doesn't capture. And I think there's enormous potential for machine learning to start to learn what features are predictive of outcomes, so that we can improve the way in which we can predict survival for these patients. And here's just an example of how machine learning can track the motion of the heart. And in fact, these colors here show the strain. So it's a way of actually understanding contractility in the heart. But we can scale this to large populations. So we can analyze the motion of the heart and here actually capture some of that complex septal motion with great accuracy and speed and make this very scalable for large populations. An example here is shown data in 300 or 400 patients with pulmonary hypertension. The model on the right shows how we can map the trajectory of motion in the right ventricle at hundreds of points in the heart. So we can get a very rich, detailed model of variation in motion, and we can put that into a neural network. Neural networks are essentially a form of data compression. So we're trying to find a simple representation of that complex motion data in a large population that's useful for predicting survival. And if we look at the survival curves at the top right, this is a composite of conventional MR parameters, and we can see how much better this 4D survival network is at discriminating low risk from high risk, and performance index there of 0.75. So this 4D survival network looks to be much more effective, much more generalizable than conventional parameters that include ejection fraction, and importantly it's fully automated. It takes the images and provides an output in terms of risk stratification, and for this disease that directly maps your 1 year risk of death, directly determines or influences what treatment you would receive. Now, the other important thing is, I think that increasingly imaging is being used to understand the development of inherited heart disease. And for here, in this example, dilated cardiomyopathy, often familial, and this is the leading cause of heart transplantation. And one of the genes that's been implicated is titin. Titin is shown in green here as this wavy spring-like molecule, and variants in that gene can affect the mechanical and elastic properties of the heart, leading to heart failure. But around 1% of people will carry a variant in this gene, but they seem to have normal hearts. So we used this computational approach to analyze their hearts, and here actually shown in red are the areas of the heart in these patients with this genetic variant where the geometry of the heart is abnormal. So superficially these hearts appear relatively normal and then all the numbers are normal, but the geometry and function of their heart shows important differences compared to those who don't have the variant. And the evidence is now that these hearts are essentially primed to fail. So when exposed to alcohol or chemotherapy or pregnancy, for instance, they can progress to heart failure. So this shows really how genetics and imaging can be integrated to understand that transition to heart failure. Now, biobank has really been transformative in cardiovascular research, and over 40,000 have now had cardiac MRs, as well as whole body imaging, brain imaging, and so on. All of them have been genotyped. There's detailed information about outcomes and risk factors as well, which has really been transformative. So I wanted to touch on just one piece of recent work where we've been looking at the trabeculae in the heart. So, of course, these are the muscular ridges inside the heart. They have a role in cardiac development, but whether they're important in adult hearts hasn't been known. But machine learning allowed us to analyze 20,000 cardiac MRs, and this can be done really in a matter of hours. And we can use mathematical techniques to measure the complexity of the heart. So we can measure these trabeculae and give a number to how complex they are in each individual. I mean, actually, we're increasing evidence now of how important these trabeculae are to mechanical function. And we can even use data to help us build up a simulated synthetic model of the heart, where we can just vary the characteristics of these trabeculae and see how they increase performance. So we can see how a more complex pattern of trabeculation improves the performance of the heart, improves the stroke work, both in patients that we've imaged in biobank and in synthetic models. So really getting down to understanding new mechanisms that underlie cardiovascular disease. So just to sum up really, the role of AI allows us to not only, I think, accelerate images, but also to provide more detailed quantitative phenotypes and actually to build up this concept of virtual hearts across populations, so we can really understand how disease develops and progresses in large groups of patients, and refine both our diagnostic criteria and the techniques we use for individual prognosis, and even begin to understand disease mechanisms and ideally perhaps identify pathways that may be amenable to treatment. So I'd like to thank all my collaborators who have been involved in this project, and thank you all very much for listening.